Morning, Tom. Good morning,
Hey, Susan.
Jessica. Hi. Just taking an inventory of board members.
Morning.
Director Lindbergh. Hello. Good morning. Hey, Robin.
Good morning, Susan. Just checking my audio.
Your audio is perfect.
Great, thank you.
Susan, I have a question. When the public speaks, are they going to turn their cameras on?
I don't know. Some do
Okay,
and some don't.
I was going to hide the non-camera, but if they're going to speak with their cameras off, then I'm not going to hide them. Okay, that's fine.
Okay, great question. Thanks,
There's
Elaine.
there's so many.
Yeah, everything will go through the chair. So
Okay.
do not worry about getting the name. We'll make sure you get all of that for the record.
Thank you.
Okay, good morning. Susan, can you hear me okay?
I can. And Chair Foster, Elaine is our court reporter this morning. She just had a couple of questions about public comment, and I let her know that any public comment would be going through you and that you would ask for each person to identify themselves for her record.
Yeah, great. I'll do that, Elaine, and I'll try and get spellings if we need any.
Yep, I'll make a list as well. The other thing, can you hear me?
Yes.
Okay. When you want to go on the record, just give me a prompt and I will let you know when the recording is good. And then I'm going to go off camera because you don't need to see me. Like, I don't need to be here. I mean, I'll be here, but. And then if there's any problems, I will try to, pipe in. Like if I can't hear somebody or if there's garble or something like that.
Yep, that sounds great, of course. I'm going to give it a minute because it doesn't look like everyone is here yet. So I'll let you know when we come to order.
Okay, great.
Member Merman here? We'll give it a moment.
I'm gonna grab my coffee real quick. Be right back.
Good morning, everyone.
All right, it looks like Member Merman has been is unable to be here right at this moment. So we are going to change our agenda slightly, and he's going to join us hopefully in 10 or 15 minutes, but we're going to get started without him because Director Lindberg has a hard stop at 10:45 today. So we will start with the hospital budget deliberations relating to Brattleboro, Mount Ascutney, North Country. I believe Member Merman will join probably in the middle of Brattleboro. He's going to try and call in as we get started, and then he'll join us. So we will change the order and we'll start with the hospitals, just so everyone knows. All right, okay. And with that, Elena, I will call to order the Green Mountain Care Board's meeting of September 11th, 2023. And today we have hospital budget deliberations. And I will turn it to Director Lindberg to start walking us through.
Thank you, Chair Foster. So we're continuing our deliberations today. We're going to start, if it is okay, still just kind of grounding us in the process that we're using to review hospitals for fiscal year 24 budgets. Talk a little bit more about inflationary growth comparisons, and then kick back into hospitals in the following order: Brattleboro, Mount Ascutney, North Country, Grace Cottage, and Springfield. And actually, I forgot to flip the slide, so we'll start with this. We had touched on the inflationary growth indicators at our last meeting. And so one way to think about cost inflation is using something that Medicare has developed, a market basket for the cost of inpatient hospital services. It does account for utilization and price. And if you look at projections from fiscal year 23 to fiscal year 24 on the Vermont fiscal year, so October to October, that's 3.1% growth. And over the 2 years of this budget process, it would be 7% growth. To be clear, this does not include any productivity adjustment. So just want to make that clear for the record. This is unadjusted for productivity. The Vermont median income growth in the same time period has been a little bit above the market basket at 3.9% from 23 to 24 and 8.6% from 22 to 24. And remembering the guidance, we use the producer provider index, the producer price index, which had a historical median inflation rate of 5.8%, but a lot of volatility, a range of 1.1 to 10.5%. Unfortunately, we don't have projections for that, which is why the market basket is what we're relying on. So
Sorry,
the way
Sarah, would you? I'm a little slow this morning. I apologize. Could you just slow down just a hair for me? Sorry.
Oh, sure. Yeah, of course. It's the first time I've ever gotten that feedback. No, just kidding.
I'm usually told I need to speed up, so maybe that's the issue.
All right, so this is trying to look at inflationary growth. So I think that's the puzzle we're all trying to solve, like how much growth is okay, and how can we keep that in line with economic growth or other growth indicators. And so one way we look at that is through the all-pair model that looked at the growth in gross state product. Through our travels, we've found that maybe that, especially given the craziness in recent history, might not be the most helpful indicator to reflect more recent inflationary pressures, not just on hospitals by any means. So that is why we looked at the Medicare market basket. That is a growth indicator that is part of how Medicare helps to establish the rates that it uses to reimburse folks. And by folks, I mean Medicare providers. So if you look at what that market basket growth is projected to be from fiscal year 23 to fiscal year 24, it is a 3.1% growth factor based on the federal fiscal year of October 1st. So this indicator was 3.3% will be 3.3% in the rulemaking with a 0.2 productivity adjustment. I just want to be clear, that's not what's happening here. This is the pure growth for the fiscal year, 3.1%. And if we look at from fiscal year 22 to fiscal year 24 projection, that growth rate is 7%. So if we wanted to keep these prices in line with that measure of inflation, that is a reference point. We also see that the projected increase in median income for Vermonters is a little bit higher than those indicators. So again, just trying to balance price growth with kind of the felt impact to Vermonters and other patients who might be receiving care at these hospitals. And below is just kind of for reference that in our guidance, we use a different indicator for inflationary growth or medical inflation, which is the producer price index by the Bureau of Labor Statistics. And that indicator, we do not have access to any projections to 24, but just for another reference point, historically, the 2-year growth rate in that indicator has been 5.8%. And if you put a confidence interval around that, you can see that it's got a lot of volatility from 1.1% to 10.5%. So does that help? Is that slow enough? Okay.
That's
cool.
Perfect.
All right. I'll try to keep it up. Let me know if I start to speed up too much. So the way we're approaching the review of hospitals this year is we start with our NPR benchmark. So again, that was established in fiscal year 23 for a 2-year growth rate, reflecting the historically high inflationary growth facing hospitals in their fiscal year 23 budgets. So that growth rate was 8.6% from fiscal year 22 actual net patient revenue plus fixed prospective payments up to what is budgeted for fiscal year 24. We acknowledge that that was an ambitious target. And again, that target comes from the all-payer model. The idea being that the growth of these hospital revenue would be somehow compared with economic growth. So we last week covered some hospitals who, 2 hospitals who were able to successfully achieve that benchmark, and their assumptions were reasonable. And then there were 2 other hospitals we looked at last week who were not at benchmark, but very, very close, and we're able to approve those. But as we do that, we consider a modification of these budgets, evaluating and weighing the reasonableness of the budget assumptions, how each of the expense factors outlined in the guidance compares with the reference ranges, how the expense growth compares with other peer hospitals, how this request compares to the Medicare market basket and wage growth, other factors and criteria set out in the guidance, which we reviewed recently, and then other factors, criteria, and principles set in statute. So last week we started by reviewing the template of Brattleboro Memorial Hospital, and we, discovered that they were quite a unique case in that they are showing quite a bit of NPR growth. So that 2-year look is a 19.9% growth in NPR. However, that's very highly driven by utilization. Brattleboro's utilization was much lower than typical in fiscal year 22. In part due to the Omicron surge. And you can see that they were approved last year for a change in charge at 14.61% and are asking for 1.5% for fiscal year 24. That is by far the lowest ask for fiscal year 24. But if we look at these reference ranges based on inflation, if we were going to try to hold this budget to 7% over 2 years, it would mean a reduction of $8 million in net patient revenue, or a negative 7.2% adjustment. And the 1-year change in charge would actually be negative, so negative 7.6 instead of 1.5. As you can see, looking at the 1-year inflationary growth over the projection for fiscal year 23, they're below that. So they're asking for less than inflation this year. So the 3.1 would actually kind of be a lift. And so, I think it's important to acknowledge that this is the only hospital whose ask was below inflation. So just to summarize some of the key indicators identified by board members. So their expense growth from fiscal year 22 to 24 was 8.9%. So that's the 62nd percentile among Vermont hospitals. For all of these indicators, a lower percentile is better, meaning that the expenses and other drivers of cost are lower, or it would be less felt by patients. Their proportion of administrative and general salaries to clinical salaries was 16.8%. So that was right around the same percentile among small rural hospitals in the comparator group from cost reports. Their case mix index adjusted cost for Medicare discharge was $9,928, which was very close to the median among their comparator group, the 54th percentile. Their standardized price for inpatient services, according to the RAND data, which was calendar year 18 to calendar year 20, all lumped together. Take all those commercial reimbursements, divide by a standardized unit of service, and you get $16,427 per inpatient discharge, which is the 29th percentile among non-teaching PPS hospitals, so prospective payment system. In other words, not a critical access hospital and not a major teaching hospital. On the outpatient side, that's $352 per service at the 71st percentile among that same group. And then if we look at kind of more longitudinal charge increases from fiscal year 19 to 23, the past 5 years, the aggregate approved rate increase was 31.4%, which is 69th percentile among all the Vermont hospitals. And if you look back for 10 years, it was just under 48%, which was 77th percentile among Vermont hospitals. So staff recommend that this budget is approved as submitted with the 1.5% change in charge, again, being below medical inflation. The growth in NPR largely being driven by utilization and the expense growth and cost per discharge and admin to clinical salaries near the median. We do recommend an additional condition for Brattleboro, and that is just some monthly monitoring as we help their data systems evolve and help improve the regulatory compliance. There's been some funkiness in their data due to staff turnover, so I think just giving them some more support will be beneficial to everyone. So that is what I'm saying, and happy to turn it back to you, Chair.
Thank you very much. Could you go back just to slide 7 for 1 second? Right, okay, so I just want to make sure I'm reading right. When you say the 5-year and the 10-year 69th percentile, that means they're on the higher end of those 5-year approved change in charge. Right, got it, okay. That's all I had for questions. I'll open it up to any board member questions or comments.
I'll go ahead and jump in. I'm comfortable with the staff recommendation. I think the NPR percentage is a little, seems high, but I think that the actual 22 utilization being low due to COVID is a confounding factor there. So I'm comfortable with it. It is a low change in charge, which I think is appropriate given their historical change in charge requests over 5 and 10 years. And I agree monthly monitoring would be helpful. So I'm comfortable.
Any other board member comment?
I'm comfortable as well.
Yeah, I think this is a good landing place for this hospital. I support the staff recommendation.
I do as well. It looks really great that they're recognizing the large increase last year in change of charge and that this year they're below inflation. I think that's a good sign that they're trying to right size that and they're making it up in utilization, serving their community. So I support this budget as well. I'll go ahead and make the motion. I move to approve Brattleboro Memorial Hospital's budget as submitted with a 19.9% increase from fiscal year 22 actual to fiscal year 2024 budgeted NPR/FPP, a 1.5% charge increase from fiscal year 23 to fiscal year 24, and subject to the standard budget conditions as approved by the board, and an additional condition for monthly reporting of actual year-to-date operating results for fiscal year 24.
Second.
And I'll turn to the healthcare advocate.
We have no comments. Thank you, Mr. Chair.
Great. And I'll open it up to public comment via the raise your hand function in Teams. I see Chris. Chris, if you could give us your, oh yeah, I know who you are. Sorry, go ahead.
Thank you. I have the great fortune of being the president and CEO here at Brattleboro Memorial Hospital. Chair Foster, members of the Green Mountain Care Board, we'd like to thank you for understanding, as Member Lunge said so well, the confounding conditions of this NPR growth. Yes, as Sarah mentioned last week, funky and odd. We certainly are completely on board with having monthly meetings. We just look forward to working with you all to keep elevating the health of this great community we serve. So thank you so much.
Great, thank you for your comment. Is there any other public comment? Okay, I think we can take up the motion since we have a second. All those in favor of the motion, please say aye.
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 Aye. Member Holmes, I thought I heard you say aye. Did you say aye?
I did say aye.
Great. Okay. All right. So the motion carries. That's 4 votes. And Member Merman did not vote on this. So we have 4 votes supporting this motion.
Oh, speak of the devil. All right.
All right. Member Merman, just to update you, no problem. We finished Brattleboro. We had 4 votes in favor and the motion carried. And Director Lindbergh will move on to the next hospital budget for deliberation.
Thank you. So next we'll be moving on to Mount Ascutney. We'll start by reviewing the summary template. So here we have just again the snapshot for the record of what we've heard so far. So notice that not a ton of adjustments over time in the net patient revenue from the submitted to budget, but for fiscal year 20, which was a humdinger for a lot of hospitals, and seeing some adjustments to that commercial NPR, and a little bit of adjustment to operating expenses in fiscal year 20. Otherwise, pretty solid budgeting that didn't require much adjustment from the board's view in the past. I'd like to highlight some very notably low numbers of an operating expense growth historically. We do see that creeping up in recent years, particularly these past 2 years. And as we talked about during the hearing, a lot of that was addressing some chronically understaffing to try to ease some of the pressure that they're feeling due to overextension there. Pardon me. And then also see some of the very low requests for charge increases over time. I think they did a good job highlighting that, they also have a very narrow band, one of the most narrow bands of requests historically. So just note also the very relative low reliance on a commercial rate. So seeing that those numbers are quite low compared to some of the other hospitals. See that they have a very high proportion of traditional Medicare in their case mix, which makes sense given the service line that they are primarily providing. Remember, they have those 10 rehab beds, which turns out is only true for about 4 or 5 critical access hospitals in the nation. So they're doing a kind of unique service up at Mount Ascutney. As far as their expense growth factors, the labor growth per FTE at 5.3% was the 6th lowest among Vermont hospitals. And the utilization has been pretty stable, so 4th among Vermont hospitals. The pharmaceutical and cost inflation data are not broken out today in adaptive. However, they were using, according to their narrative, they're using local factors that account for their costs, and those were in line with the benchmarks as listed here. As far as financial performance, they are right in line with Vermont hospital medians, have a bit more cash on hand than is at median. However, not necessarily a red flag, not seeing any concerns related to that from a staff perspective. And also, seeing that a relatively impressive job of keeping up with capital investments in this cycle, which is also notable. The ratio of administrative and general salaries to clinical salaries was 22%, which was the 8th lowest among Vermont hospitals and the 75th among their comparator group. I'm sorry, the 75th percentile among the comparator group of critical access hospitals on cost reports in fiscal year 22. And then that's that $29,000 cost per Medicare discharge, again, is related to the service line. I did not have time to pull the data compared to those other 3 to 4 hospitals, but it's pretty clear that that's related to the rehab facility function that they're offering. So they are the highest among their peer group, but that's mostly a reflection of their service mix. And then when we do look at the relative cost and price, we see a lot of stability here. For the pandemic years, impressive to see that they were able to improve their cost coverage during the pandemic, and seeing that, you know, they're right at the 75th percentile as of fiscal year 22. Again, given their very different case mix, not case mix, their service mix, that's an impressive indicator. And for outpatient services, seeing that that is, you know, dropped a little bit since it dropped a little bit and has, sorry, I can't quite see that last value. Dropped a little bit and then come back up a little bit, but seeing that the actual price is within that standardized price bucket leads me to believe that, you know, they're doing well among their peers on outpatient price. Any questions about the record before we turn back to the presentation? Okay. Bear with me, I am very slow screen switcher. Okay, does everyone else see Mount Ascutney's budget request? Wow, okay, great. So we see that the NPR request from the 22 actuals to the 24 submitted is $8 million, which is a 12.4% increase. Their change in charge over the 2 years is 9.8%. And that is among the lowest 2-year requests that we saw in the budgets coming in this time period. If we're going to compare it to the inflationary reference range, we would see that they actually would get a $1.5 million raise compared, as they were one of the few that came in under inflation last year. But if we were going to only allow a 3.1% increase over the fiscal year 23 projection, that would be a reduction of $1.3 million or a 2% cut. And if we look at their performance over time, so again, that expense growth in the immediate year or two has been a little bit higher than is typical for this institution. They're usually among the very lowest in expense growth, but for this time period, it was 12% at the 69th percentile. Their ratio of admin and general clinical salaries, again, is at the 75th percentile among critical access hospitals at 22%. Talked about how that inpatient amount per discharge is deceptive, given the very different service mix they have with the 10 rehab beds. So not a helpful comparison in this specific case, but they were kind enough to send those hospitals over, and I would highly recommend making sure to use that comparison group in the future. But you can see for outpatient prices, they're at the 34th percentile among critical access hospitals. So that you know, helps balance some of that out. Again, the past 5 years, they were the 7th lowest in terms of charge increases. In over 10 years, the 41% increase cumulatively was the 31st percentile. So just not a heavy reliance on rate over time for this hospital. So staff recommend that this budget also be approved as submitted with the 12.4% growth in NPR and FPP, and approve the 5.1 change in charge. I think I've maybe belabored these points, but just to say it one last time with feeling, their charge requests, they're among the lowest charge requests for the past 2 years, prior history of managing their expense growth, and historically low reliance on the change in charge in comparison with other hospitals, especially in the past 5 years. So with that, I'll turn it back to you.
Thank you. I feel like needling member Merman first, since he was tardy today. Member Merman, do you have any comments or questions?
Thanks. Yeah, I agree with the staff recommendation. I think it's notable. I think Director Lindbergh points out the complexity of evaluating Ascutney based upon their standardized inpatient price and their cost per inpatient discharge because of their unique situation. So I think I appreciate that analysis, and I also appreciate that their standardized outpatient price is very low, and they've had pretty low commercial increases over time and seem to be very well managed to their costs. So I'm totally supportive of the staff recommendation here.
Great. Other board members?
The only thing I would add is it's also notable that they're very close to being on track to their budget in 23 projected, with a very small operating margin this year under 1% and a request of only 1.5% operating margin for next year. So I think that's notable as well.
Yeah, I'll just say that I think the budget was reasonably proposed, well supported by the data, and I really appreciate the staff's analysis and their recommendation. And I appreciated the reasonableness of the 2-year change in charge from this hospital. But I agree with the recommendations.
I agree with the recommendations as well.
I do as well. In terms of ensuring affordability for the state and their community, being really close to the 2-year inflationary growth is on the change of charge is a really strong piece of their submission. So I want to call that out and recognize that the historical managing to expenses and keeping expenses down is really strong. So I support the recommendation. Therefore, I will move that the board approve Mount Ascutney Hospital and Health Center's budget as submitted, with a 12.4% increase from fiscal year 2022 actual to fiscal year 2024 budgeted NPR FPP, a 5.1 charge increase from 2023 to 2024, and subject to the standard budget conditions as approved by the board.
Second.
And I will open it to public comment. I'm sorry, I'll go to healthcare advocate first, please.
Thank you, Mr. Chair. I guess I probably should have said for Brattleboro that we had no further comments. So I will, for Ascutney, say the same thing. We have no further comments. We stand by our comments, our written comments, which simply is that we recommend a 2.8% increase in NPR, equivalent to Vermont's real GDP growth. Thank you, Mr. Chair.
Thank you. And your public comment, I think, is posted if anyone wants to see it. Any public comment? Okay, all those in favor of the motion, please say aye.
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 Aye. Motion carries unanimously, and the budget is approved pursuant to the approved motion.
All right, so next up, we'll turn our attention to North Country Hospital. So I'm sure you're aware they are going through some especially tough financial pressure. In addition to the challenges faced by all our hospitals, they have the added challenge of some bumps with the Cerner implementation, their electronic medical record, which made their fiscal year 2023 operating results especially rough. But you can see that just a lot of red in these recent years, especially this year to date for fiscal year 23, makes us concerned for their financial welfare. Can see that they are highly reliant on Medicare and Medicaid as payers, with only 28% of their gross payer mix coming from commercial. And we do see that their labor expense growth is among the lowest. I think I've flipped that ranking. Let me make a note to get that fixed for the record. That would be among the lowest expense compensation per FTE growth in the state. And their utilization at 9.8% is ranked third, and cost inflation. Again, I think that one is flipped. So that's among the higher side of cost inflation among Vermont hospitals, largely due to the small numbers and fixed expenses that small hospitals face. So the financial indicators, again, really hard to look at. Notable that, you know, they're submitting a very modest margin for fiscal year 24, working on rebuilding some of their cash reserves, and just very clear about the row they have to hoe. As far as the ratio of administrative and general salaries to clinical salaries, they were ranked 10th among Vermont hospitals at 24%. And again, due to the small size, largely they were at the 88th percentile as compared to their comparator group. However, their CMI adjusted average cost per Medicare discharge is third lowest among Vermont hospitals and was at the 29th percentile among comparator groups. So quite an achievement given some of the fixed costs that they're facing. And it looks like these numbers weren't filled in. I'm so sorry. But let me flip back over to the budget tool so that I can give you that information. Brand is what we want. So we'll see here that North Country, again, from this calendar year 18 to 20, was at 25,000 per standardized price per inpatient discharge, which is above the 75th percentile. And the 477 standardized outpatient service was also above the 75th percentile. So seeing, again, relatively high prices for commercial at North Country Hospital. And you can see the cost coverage. We'll go back to that tab. And again, apologies for missing that. But we see that in fiscal year 22, that North Country Hospital cost is quite low, and the reimbursement is 211% of that for commercial. And that looks a little bit different inpatient versus outpatient. So on the outpatient side, it's 261% of the cost, Medicare allowable cost, and on the inpatient side, it's 133. So among the higher levels that we see among our hospitals. And so, any other questions about the budget summary and at this point, before I turn back over to the presentation? Yeah, apologies for that. We'll get that fixed. All right, so looking at it from this angle, we see that the growth from fiscal year 22 actual to 24 budget as submitted is $18 million, which is a 21.3% increase. And the change of charge, the board approved a 12.24% increase in fiscal year 23, and North Country's requested 4.5% in their fiscal year 24 budget for a growth rate of 16.74%. We are going to try to hold them to 7% over the 2 years. That would be a $5 million reduction in their budget, or 6.1%. Yeah.
I have on my screen suggested motion language for Mount Ascutney.
Okay.
Yeah, there we go. That's what I was looking for. Yeah, great.
Okay. All right. Yeah, no worries. It's funny when it doesn't sync up. So that would be a negative 5.2% rate increase from the 23 projection to the 24 budget. And if we were to hold them to inflationary growth at 3.1%, that would be about $1.5 million reduction, which is 1.3% of NPR, and would keep them at 15.34% over the 2 years. When we look at their performance summary, their expense growth at 8.2% is below median at the 46th percentile. They do have a relatively high proportion of admin and general salaries to clinical salaries at the 88th percentile. A lot of our critical access hospitals cluster right around that point. The CMI adjusted cost per Medicare discharge is the 29th percentile among critical access hospitals. The standardized price for inpatient, 80th percentile among critical access hospitals. And on the outpatient side, the 85th percentile. So again, seeing that relatively higher price for commercial payers. But we can see that over the 10 years, they have had the highest aggregate rate increase at 56.5%, but more below the median in the past 5 years. So less approval of rate in the past 5 years as compared to the longer term. So the staff recommendation would be to modify the budget as submitted. We would recommend adjusting the NPR growth from 21.3% to 20.7%, adjusting the operating expenses accordingly by $496,000, and achieving that by reducing the change in charge from 4.5 to 4%. This is really just about the high relative commercial prices. However, they also have some significant cost saving initiatives underway. And again, I think that just given the magnitude of financial challenges they're facing, I wouldn't recommend adjusting it any more than that, just in terms of sustainability. And to that point, I think monthly monitoring would also be helpful, especially as the Cerner implementation evolves. So that's what I've got. Back to you, Chair.
I've heard of some of the cost-saving initiatives. Do you, off the top of your head, recall what any of those? I thought there was an effort to share some services, perhaps with NVRH.
There's shared services initiatives. They're working with both Dartmouth and UVM to help provide some services. They also outline their position management control. So before they would fill a new position, they would see if they could cover it through other capacity. And they also are mentioned just kind of being as creative as possible in trying to get more leverage in some of their prices and contracting.
And then the Cerner implementation issue, are they about through that problem? Is that mostly a historical issue now?
I think it's still underway, and it's still unclear about how much, if any, remedy will be possible for what has occurred.
I support your staff recommendation. I had heard about the shared services initiative. Maybe that was in their narrative as well, and that's what we want. They're seeking opportunity to find savings, and the change in charge is not large, but compared to 1 year inflation, 4 is relatively low compared to some of the others. So I would support this recommendation. Any other board member questions or comments?
So
I support the Go ahead, Tom.
Thanks, Jess. I think I can come around to supporting the recommendation. I am concerned their payer mix, they have a small commercial base, and they've been, the prices have been rising rapidly over a long period of time, and trying to build a sustainable operation with unaffordable rates, the math doesn't work. So I'm happy to see the cost savings initiatives. And I believe I can approve this, but I want to carefully watch their admin to clinical ratio and their commercial prices in the future.
I can support the recommendation. I share some of the concerns referenced by others. about their prices, the growth in prices. One of the things I would also note, which gives me a little optimism that they can perhaps lower some of their expense growth to meet this reduced change in charge. And the follow-up that we requested on the breakdown of expense growth price assumptions, their assumptions about in price inflation or inflation on medical and non-medical supplies was 11%, which is higher than any of peers or most of their peers. So the hope would be that they can revisit that assumption on their medical and non-medical supply growth costs, perhaps find some savings there, speaking to some other hospitals that submitted a lower expected increase in prices of those supplies. And so I think that there's room here for this hospital to meet this reduced change in charge and still serve their community. So I support the staff's recommendation.
I'll jump in. I also support the staff's recommendation and also share concerns that Member Walsh and Holmes and Foster, Chair Foster mentioned, as well as Director Lindberg. I am really concerned that for similar reasons that, they have a small proportion of commercial revenue, but very high commercial prices. And I think that 10-year trend helps us see why on the RAND pricing data, they start at the highest. And so when we apply rates to that, it looks higher. So I am very concerned about that. I think budgeting an operating margin that's essentially zero, and the challenges that they have had with the Cerner implementation, I'm hoping that all of that's going to pan out to being a much better year for them. And so I think coming into next year, I'm optimistic that we're going to see a hospital that has better performance than they expected, even with this slightly reduced change in charge that I think at least now we have a majority supporting.
The only thing I have to add, I'm in agreement with what others have said, is that I was glad to hear that North Country and NVRH were jointly doing a regional assessment, which I hope will allow for this hospital to address the issues that have already been highlighted. I think even getting to a zero margin, quite frankly, will be a heavy lift given some of their challenges, but I wish them luck. I can go ahead and
Director
make the motion.
I had one other last question for Director Lindberg. Please go back one if you can. The NPR FPP adjustment, can you give me a little of your thinking behind that?
Sure. The thinking there is I don't know a lot of other pathways for them to make up that NPR and FPP. And so I would recommend adjusting both the NPR and the operating expenses to try to keep that margin whole. However, if they were to if they're able to find that revenue through utilization or non-commercial revenue, I would hope the board would support that when it comes to seeing the actuals for fiscal year 24.
I see. Great. Thank you. Member Lunge, if you had a motion, we're ready.
Sure. I would move to approve North Country Hospital's budget as modified with a 20.7% increase from fiscal year 22 actual to fiscal year 24 budgeted NPR FPP, which is reduced from 21.3%, and a commensurate reduction in operating expenses from the submitted budget, a 4% charge increase from fiscal year 23 to 24, reduced from 4.5%, and subject to the standard budget conditions as approved by the board, with an additional condition for monthly reporting of actual year-to-date operating results for fiscal year 24.
Second.
Any comment from the Healthcare Advocate's Office?
Just the same comment, Mr. Chair. We stand by our written comments.
Thank you. Any public comment via the raise your hand function? Hearing none, I think we can take the motion on the floor and vote. All those in favor of the motion, please say aye.
Aye.
I,
I think I heard an extra yes on that from Walnut. I am also an aye, so the vote carries unanimously.
All right, to quote Bon Jovi, we're halfway there. We want to keep going or take a recess or mess with the agenda. Just want to make sure we're
It looks to me like we're doing okay on time, given your hard stop at 10:45. So why don't we indulge ourselves with a 6-minute break till 10 a.m.
okay. Thank you.
Thank you. We'll go back on the record at 10. Great, perfect, thank you. Director Lindberg, take it away.
All right, next up we have Grace Cottage Hospital. As you can see, the board has made some adjustments to their budgets for 3 years in a row, fiscal year 20 through fiscal year 22, including some adjustments to the commercial NPR and operating expenses just in fiscal year 21. You'll see that this hospital also has a relatively low reliance on commercial rate, so maxes out at about 2%, so that's among the lowest for Vermont hospitals. Despite that, we do see some pretty robust operating results in the recent years. It's hard to interpret fiscal years 21 and 22 due to the CARES Act supplemental funding. But again, you see that for gross revenue, commercial is a very small proportion of their service mix or payer mix. Their growth in labor expenses per FTE is among the lowest of Vermont hospitals. One moment, please. And the utilization at 6.7% was 8th. They noted in their budget submission that their NPR growth would have been close, if not right at the benchmark of 8.6%, but for the utilization. And I think that validates that assertion. And their cost inflation at 3.0% is near the middle of Vermont hospitals and within benchmark. As far as the financial indicators, one thing that is unique to Grace Cottage is that they tend to budget a negative operating margin and are able to supplement that with the generosity of donors in their community. However, we actually see a reduction in the budgeted margin from the year to date. We also see a relatively healthy total margin. A lot of that has to do with some planned capital expenditures that are ongoing. And their days cash on hand is a little bit below the median for the state. See that again, pretty, considering how old some of their plant is, these numbers are also below median compared to hospitals, which is notable. They are the highest in terms of the ratio of admin and general salaries to clinical salaries at 36%. As we covered in the hearing, this is largely due to the fact that they are quite small, even for a critical access hospital. So that is the highest not only among Vermont hospitals, but among their comparator group. But their CMI adjusted average cost per Medicare discharge is also a bit high at the 83rd percentile among their comparators and the 11th highest among Vermont hospitals. So that is, again, largely due to the service mix and low numbers. So we don't even have comparator information due to the low numbers for some of our indicators, as you'll see on the next page. So we don't have a standardized price from RAND due to the low numbers, but when we look at the commercial cost per discharge, we can see that it's above the 75th percentile, and the cost coverage is below the 25th percentile. So not getting a lot of cost coverage out of commercial for inpatient. It does look more significant on the outpatient side, where their cost is below the 25th percentile per discharge, and the cost coverage is at 167%, again, below the 25th percentile. But that actual standardized price is well within the interquartile range, which is the distance between the 75th and 25th percentile. Any questions about the summary before we turn back to the PowerPoint presentation?
Can I ask you just one quick price on the commercial cost per discharge? That seems pretty high. It seems like they may have maybe not as formalized as Ascutney does with a rehab type facility, but they do get a lot of rehab patients. Do you think a similar logic applies to their commercial cost per discharge as Ascutney?
Absolutely, absolutely.
So kind of complex patients that have a long length of stay that are less acute. It's kind of what my impression of that is.
I'd say that would be a fair summary. All right, well, I'll turn to the other document momentarily. All right, are we seeing Grace Cottage's budget request? Wonderbar. All right, so we see that again from the 22 actual to the 24 submitted, it's an increase of $4 million, but given their size, that's a 16.4% increase in NPR. They have, if not the lowest, among the very lowest requests for change in charge from fiscal year 22 actual to fiscal year 24 submitted at 9%. If we were going to try to govern this at 7% over the 2 years, since they were one of the few hospitals that came under 2 years of inflation in their request last year, that would mean a 2% raise or an increase of about $500,000. If we were going to restrict the increase for fiscal year 23 at 3.1% over that projection, it would mean reducing their NPR by $238,000 or a minus 0.8% adjustment. Again, just kind of talked about some of this, but their expense growth at 14% or 13.8% from fiscal year 22 to 24 is right around the 75th percentile. Have that notable highest ratio of admin and general salaries to clinical salaries. Their adjusted cost per discharge, given their service mix, is at the 83rd percentile among critical access hospitals. We don't have a standardized inpatient price from RAND due to low numbers, but on the outpatient side, they're at the 60th percentile at $366 per outpatient service. Again, that 5-year trend, they're at the 15th percentile in accumulated rate increases, just below 20%, and still below median if you go back the 10 years at the 46th percentile. So not showing an relatively higher reliance on commercial rate. It's relatively lower reliance on the rate increase. Staff recommendation, approve the budget as submitted with a 16.4% growth in NPR and FPP, retain the 4% change in charge. Our rationale being, again, that low reliance on charge requests, especially in the past 2 years. Utilization being one of the major drivers that prevented them from maintaining budget at benchmark. And again, the low charge request over the longer term. So back to you, Chair Foster.
Thank you. Board member questions or comments?
So this is Tom. I believe one time last week we discussed if an organization were an outlier on any of the measures, could we approve the budget, but require monitoring or some type of well, I guess it'd just be monitoring. I'm concerned about the admin to clinical ratio being so high here. I think there's justification to go with the recommendation, but I'd like to better understand how they're calculating their admin to clinical ratio. There's discretion in what goes into line 5 on the cost report. So understanding what they're doing and then developing a plan to reduce that as appropriate once we better understand what's going on. I think that's an important piece here. I'd like to see that added to the motion in order to approve as is.
So just to make sure I'm picking up what you're putting down, so in this order specifically, kind of deep dive on the cost report and a plan to address that ratio.
Yes.
This is Dave. I'm supportive of both the recommendation and of trying to understand that admin clinical ratio specifically for Grace Cottage as well. I think a few other things I'd just sort of like to highlight is this 15th percentile among Vermont hospitals in the FY 19 to 23 change in charge increase of 19.6%, 19.6% charge increase over 5 years is less than some charge increases over 2 years for many hospitals. So, and the total amount of commercial reliance for Grace Cottage is very low. So I think those two things just make me pretty comfortable, even if this admin to clinical ratio is true. I mean, it seems like an outlier in the rest of the performance of the hospital, but I'm supportive of going with the requested rate and staff recommendation.
Any other board member comment or question? Okay. I have one thought sort of similar, and I'm not sure it really advances this discussion or this review much, but I would just flag that I don't really have a very good sense of how reliable prospectively the generous nature of the community is. And the lowish days cash on hand and the high admin costs and high discharge costs is just something to flag. I have no problem with the submission. I agree with the staff recommendation, but just looking ahead, if those donations aren't there, these signs are a little bit more troubling for me. I'll just leave it there, that this is a good submission and it's a low change in charge and it's not too far off from 1 year or 2 year inflation, but there could be more difficulties should the market change a little bit. But I support the submission.
I'll just agree with that point and just say I think the monitoring is going to be important with this particular hospital. And I do hope that as we move into Act 167, that this is a hospital and a community that really engages in that work to try and find a sustainable path that perhaps doesn't rely so heavily on donors in their community and their generosity to make a margin. So, but I do support this submission for the reasons that others have outlined.
I can make the motion. I'll move to approve Grace Cottage Hospital's budget as submitted with a 16.4% increase from fiscal year 2022 actual to fiscal year 24 budgeted, NPR FPP, a 4% charge increase from fiscal year 23 to 24 and subject to the standard conditions as approved by the board.
Second.
I'm sorry to interrupt. There was a additional condition suggested. Yeah.
Right. The monitoring.
I believe it was to investigate the details of the admin to clinical salary ratio and develop a plan to address it. But I see Mr. McCracken on screen to save me.
I think that's what I heard as well, but certainly defer to board member Walsh to correct that if we're missing something.
No, I think that's right. I'd like to better understand the ratio as it's used at Grace Cottage. I don't think we don't want to require any specific language about a target, for instance, getting below the 75th percentile or something. I don't think that's necessary here, but I would like to better understand how they're calculating and to start monitoring that with them.
And Member Walsh, is your preference to have that as a formalized condition in the budget order, or something to do just through our oversight and work with them? What's your?
I'm happy to do it with oversight and working with them.
Yeah, I think that would be beneficial for all hospitals, just given what we've seen in the variation. So to highly recommend.
I'm okay with Member Walsh's proposal as he just indicated. Is there any other board member reaction or comment?
I'm supportive.
Okay. Okay. So I think the motion I made, Mr. McCracken, correct me if I'm wrong, but I think the motion I made can stand, and we will just need a second if there is one.
Second.
Any comment from the healthcare advocate?
Morning, this is Sam here. I think the board knows where we stand, so thank you. Appreciate it.
Great. And any public comment? Here, Mr. Wright, Peter Wright, please go ahead.
Thank you, Chair. I think the concept of looking at it in the whole across the state and understanding why there may be variation from hospital to hospital is an important thing to understand before any recommendation in any direction would be made. So I certainly support better understanding the data. We, of course, along with I'm sure the rest of the hospitals, will gladly participate in that analysis.
Great, thank you. And just I'll flag for the record, Mr. Wright, I believe, is the CEO of Northwestern.
Yes, sir. Thank you very
much. Of course, yeah. Any other public comment? All those in favor, please say aye.
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 Aye. And the motion carries unanimously. Director Lindberg, back to you.
You betcha. All right, so the last hospital on the docket this morning is Springfield. As I think folks are well aware that this hospital is still in the process of recovering from Chapter 11 bankruptcy. They are still addressing some of the restructuring required. They split from the FQHC and can see that there were some adjustments to their fiscal year 21 and 22 budgets, a pretty substantial one in fiscal year 22. And we see that their reliance on the commercial rate has been appearing to increase, but that it's still on the relatively lower side of some of our hospitals. And again, just see some pretty troubling financial results leading up to that bankruptcy. See that the fiscal year 23 information is missing. So that's another kind of, we would like to, or I would suggest kind of continuing monthly monitoring to try to get the data flowing a little bit more efficiently. As far as their labor increase, it's at 13.6%, which was the 9th number, right near the middle of the pack in terms of that growth rate. Their utilization is quite high. That is due to their success in finally recruiting some providers and getting other providers up and running in the community, seeing a Substantial decline in their pharmaceutical expenses, largely due to they are no longer providing oncology services. So that's mostly due to a change in what they're providing, and their cost inflation at 3% is again right near the middle and within the benchmark. Very modest operating margin budgeted for fiscal year 24, but year to date, seeing the negative 4.2 makes that quite a stretch. Can be hard to predict year end, especially with timing of grants and other information. But that's a pretty substantial lift for 1 year. And also see these age of plant numbers, meaning that capital improvement probably needs to be addressed in the near term for this facility. Their ratio of admin and general salaries to clinical salaries is at 21%, which was the 7th lowest among Vermont hospitals and below the 25th percentile among their comparator group. So a pretty favorable result there, showing some of their efforts to manage expenses and reduce administrative expenses. And their CMI adjusted average cost per Medicare discharge at $13,690 was the 10th highest among Vermont hospitals and right at the median among the comparator group at the 54th percentile. They are showing quite low cost per discharge at $10,485. They're below the 25th percentile among Vermont hospitals, and showing substantially improved cost coverage. So again, that to me might be a signal of really focusing and working on that expense management, and also right-sizing the services that they're providing. And then for standardized price for inpatient, they're right in the interquartile range, a little bit closer to the, is that right? No, right in the middle there, so near the median. And then on the outpatient side, we see that they are pretty stable in their cost per discharge over time, or cost per outpatient service over time, and that their cost coverage again is improving. So seeing those improving both on the inpatient and outpatient side, and I think adds credence to the idea of expense management being a part of that story. And their standardized price for the 18 to 20 period was just a bit above the 25th percentile. Any questions about this summary before we turn to the presentation again?
Sal, can you just go back to Director Lindbergh? Sorry, can you just go back to the admin to general ratio? Okay, can you just say what you said again about the ratio in terms of the percentage? I'm looking at the 25th percentile is 11% and the 75th percentile is 22%.
Yeah, I think I don't have I think those are the reference points for PPS hospitals. So I will correct that. All apologies. The percentile is correct though.
Percentile is correct. Okay, thank you. All right.
Yeah.
Okay, thank you.
You're welcome. Okay, I can turn back to our presentation. All right. Does everyone else see Springfield? Great. All right. So we see here that the growth from the 22 actual to the 24 submitted is $8 million, which is 15.6% for them, and that they were approved for a 10% charge increase last year and are requesting 6.95 for this year for a 2-year change in charge of 16.95. That's a little bit towards the upper range of what we're seeing from hospitals. If we were going to try to constrain that to 7% over 2 years, it would be a minus 3% rate increase for the current budget. And holding them to just 3.1% growth over their 23 projection would be a reduction of $2 million or 3.4% of their NPR. So again, the expense growth here, we see 6.4% in their growth from 22 to 24, which is the 31st percentile among Vermont hospitals. So just a bit of, within that interquartile range. That proportion at the 54th percentile. So yeah, I'll get that right on the other document. This one, sorry about that. I'm just doing too many numbers all at once. So this I just did, so I know this is correct. So right near the median. The CMI per adjusted cost per Medicare discharge is at the 79th percentile among their peers. The standardized price for inpatient is near the 25th percentile, so 34th percentile, and the 31st percentile on the outpatient side. Also see that over time, not a relatively lower reliance on rate increases. Their cumulative increase from 19 to 23 was 32.3%, which is the 35th percentile, and then longer range increase at 34.6% is the 15th percentile. We'll note that the bankruptcy certainly affected the charge increases during this time period. So that's definitely part of the story on that. So staff would recommend an adjustment on the change of charge from 6.95% to 6%, and an adjustment to the NPR and FPP that aligns with that. So basically a 1% reduction in the growth of NPR and FPP, which is an expense reduction of $516,000. Part of the reason for this adjustment is that the year to date, again, they're showing to be about 3.5% below their budget. So just want to kind of reflect that they might need to rescale or rebase some of their assumptions. Their cost per discharge is a bit high, but they also have a history of relatively low rate increases and also starting from a lower price. So those rate increases are not materializing to as much commercial rate as some of their peers. And then finally, just continue the monthly monitoring as they navigate this recovery from Chapter 11. Back to you, Chair.
I will open it up to the other members for any comment or questions.
I'm supportive of the staff recommendation. I think the downward adjustment is prudent given where they're coming in on their 23 projected. I think this has been a concern with this hospital for a number of years, just that their ramp up out of bankruptcy has not been as fast as I think they optimistically hope for. So I am supportive of the recommendation.
Robin, can I ask you just a question on what you said there, just so I understand? Were you saying that you're concerned that their revenue is under budget and they haven't come out of bankruptcy as fast as expected? Is that what you said?
Yeah, I think what we've seen with Springfield as they've tried to hire providers and ramp up is that their NPR assumptions are optimistic and their expense assumptions are built to the NPR assumptions, which then results in an operating loss. And it is a big jump to go from where they are now to in 23 projected to the 24 ask. And so what we've seen in prior years with other hospitals who similarly budget their NPR based on their expense needs is that it kind of builds in a loss. And so making a small adjustment like this, I think could ensure a little more conservatism in the NPR and hopefully mean that they'll be able to make their margin next year.
Yeah. Okay, thank you. I guess my concern with Springfield is they have low days cash on hand, recovering from bankruptcy, I think they've been very focused and trying to rebuild confidence in the hospital and trust in the hospital, and their utilization seems to be increasing with that effort. I think also one of my thoughts with their rate is that they, when you look at that 10-year rate increase and the 5-year rate increase, the 5 years, the first set of 5 years is where they got really low rate increases and then went into bankruptcy, because the bankruptcy occurs in the most recent 5 years. And it's amazing to see how close those two numbers are, 32.3% and 34.6%. So while they've had pretty substantial rate increases over the last 5 years and over the last 3 years, specifically, their commercial prices, especially for outpatient, are so low to begin with, as Sarah mentioned. I don't think they're able to realize a whole lot of revenue off of those increases compared to other hospitals like, say, North Country, who start with pretty high commercial prices to begin with. So I'm supportive of the staff recommendation. I think that, it's a higher rate than a lot of other hospitals are asking for, but they have a larger recent rate growth. But I think looking at in the context of their longer term prices, they're still a very low price for outpatient service for commercial provider hospital. So I think that a little bit more substantive charge increase compared to peers is warranted here, which I think 6% provides.
Any other board member comment or question?
Just said that I can support the staff recommendation as is.
I support it as well.
So one question I had, the monitoring, is that any different than what we've been doing the last, as far as I know, the last year?
Yeah, we've been doing it since the Chapter 11, just meeting each month and kind of reviewing the current state.
But no change in that?
Yeah, I would recommend continuing that convention, yes.
I support your recommendation from the staff. I move to approve Springfield Hospital's budget as modified hereby, with a 14.6% increase from fiscal year 22 actual to fiscal year 24 budgeted. MPR FPP reduced from 15.6, and a commensurate reduction in operating expenses from the submitted budget, a 6.0% charge increase from fiscal year 23 to 24, reduced from 6.95%, and subject to the standard budget conditions as approved by board, and an additional condition for monthly reporting of actual year-to-date operating results for fiscal year 24.
Second.
Any comment from the Healthcare Advocate's Office?
Nothing beyond what you'd expect. We stand by our recommendation. Thanks a lot.
Thank you. And any public comment? Mr. Adcock, I'll just introduce you as the CEO of Springfield Hospital. Please go ahead with any comment you may have.
Good morning. I hope you can hear me okay. Just want to, Chair Foster, I'd like to thank you and the other members of the board, the staff, particularly Director Lindberg, for all your help with the budget process this year. And just like to recognize the work that's been done here at Springfield by our hospital family over the last few years, as we've worked really hard to address the financial situation that we've had at the hospital. So we continue to be confident that we're moving the hospital in the right direction, and we appreciate your support as we continue those efforts. But I certainly want to recognize our hospital family and our community for the support we've received and the hard work that everyone has done to continue to move us forward.
Well, thank you for your comment. Any other public comment? Okay, all those in favor of the motion, please say aye.
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 Aye. And the motion carries unanimously. It is 10:36, and I believe Director Lindberg has a hard stop, 10:45. So we'll let you go. I think you've worked enough hours the last few days, so thanks for all you've done.
Yeah. Thank you. See you soon. Bye.
And I think it'll make most sense to take up the remaining hospitals Wednesday and Friday, since Director Lindberg won't be here. I'd prefer to have her here for the other ones. And with that, we reversed our agenda a little bit, and so I'll turn to what had been our first agenda item, which is a recusal request from the University of Vermont Health Network relating to Dr. Merman. So Dr. Merman, I'll turn it to you.
Thank you, Chair Foster. I think recognizing that the board faces this deadline to deliberate and vote on the remaining hospital budgets by this Friday, September 15th, I've decided to abstain from participating in voting on the FY24 budgets for UVM Medical Center and Porter Hospital. The request from University Health Network that I not participate came during the hospital budget hearings, and asking my fellow board members to dedicate the time to discuss and deliberate on that request detracts from the limited time the board has left on our schedule to make the decisions on the remaining hospitals. So since I won't be participating in the deliberations and votes for the FY24 budgets of UVM-MC and Porter, the board does not need to spend time on this to make a decision on UVM Health Network's request.
Great. Well, that helps us with timing. I appreciate that very much, Dr. Merman. I don't think we have anything else on the agenda. And so is there a motion to adjourn?
So moved.
Second.
Second. All those in favor, please say aye.
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 Aye. And motion carries, and we're adjourned. And I think we'll see you on Wednesday. Thank you, and have a good day.